Welcome to the Institute of Medicine of Chicago. Hello, my name is Pat Meriwether Argus, and I'm a member of the Board of Governors of the Institute of Medicine of Chicago and co-chair of the Institute of Medicine of Chicago Program Committee. In addition, I'm the Executive Director of Project Patient Care. It's my pleasure to welcome you today. Today's session is the third session in our April program series, Leveraging the Power of Research to Improve Community Health and Wellness. We are pleased once again to host this program with Rosalind Franklin University. Overall, this program series with RFU provides unique opportunities for interprofessionals to work together to achieve better well-being and healthcare equity. IOMC is deeply committed to addressing the social determinants of health and achieving health equity for all. This is the heart and DNA of IOMC. IOMC has a long history of bringing awareness and creating systemic change in our history. We worked for more ambulance accessibility for South and West Sides in 1945, established an African American Health Commission in 1954, advocated for hiring Black physicians in hospitals in 1954, and with great intentionality focused on eliminating health disparities in 2004. IOMC continues to focus on achieving health equity and social determinants of health. Today's program unites with many of IOMC's vision and mission uniting and leveraging the power of research to improve community health and wellness. Our collaborative initiatives are the nexus of achieving community health, population health, and public health. We hope you will agree at the end of this series with Rosalind Franklin University. Today's agenda includes a panel discussion, question and answer period, and updates on the future programs and speakers. It is our pleasure to welcome our panel today. We are pleased to welcome moderator and session leader, Dr. Ronald S. Kaplan, Executive Vice President for Research, RFU Vice Dean for Research, Chicago Medical School, Dr. Maureen Benjamins, RFU part-time faculty, senior research fellow, Sinai Urban Institute and fellow, IOMC. Dr. Melissa Chen, clinical director, RFU Interprofessional Community Clinic, Dr. Robert Marr, assistant dean for research, Chicago Medical School, and Dr. Kristen Schneider, associate dean of research, College of Health Professions. Today's learning objectives are to describe how community members and organizations can be integrated into research collaborations to positively impact the health and well-being of a community, identify how students can be involved and impact community-centered research collaborations, and explain how Joanna Briggs Institute methods enable nurse anesthesia residents to conduct impactful patient-centered evidence synthesis and implementation research, and to discuss the impact of RFU's new innovation and research park, Helix51 Incubator, and the expected impact of the RFU Center for Health Equity Research. This program is accredited by Rush University and affiliated associations. You will be able to obtain your continuing education credit at the end of the program. Our speakers have completed their conflict of financial disclosures, and this information is on file. On behalf of the Board of Governors, it is my pleasure to warmly welcome everyone today. We are honored with your overall support of IOMC. The overall attendance at this virtual session has surpassed over 1,000 attendees in the past year. If you are visiting us for the first time, we conduct monthly virtual sessions, except during the months of July and August. In the fall, we expect to begin our work groups. Please stay tuned for more information on how to become more involved with IOMC as a fellow. If you are not a fellow and would like more information on membership, please contact Deborah Hodges, Associate Manager and Program Manager at IOMC, staff@iomc.org. IOMC is celebrating our 106th year, and in June, we will have reached our 107th year as an organization. IOMC is an independent, not-for-profit organization of distinguished leaders in the health field who collaborate to improve the health of the public. We are proud to draw upon the diverse membership and other regional leaders to address critical health issues. In addition to today's session, additional complimentary sessions will be held on April 29th, building networks to solve critical nursing workforce need in the greater Chicago metropolitan area. The speakers are Dr. Sandra Larson, founding dean of the College of Nursing and vice president of partnerships at RFU. She will be joined by Dr. Shubnik, Deb Berman, professor of biological sciences, senior director for science partnerships of Lake Forest College. Also on May 6th, IOMC is hosting the virtual program, Systemic Issues Impacting Chronic Kidney Disease and Health Equity. Please join us for these two upcoming sessions. We are excited to get together in our annual meeting in the IOMC Healthcare Awards on June 30th. The 2022 IOMC Healthcare Awards are open for nominations now. There are 7 award opportunities. The deadlines are May 2nd and May 4th for specific award types. Please consider nominating a colleague or an organization this year. The awards will be presented at the annual meeting celebration. Please look for more details soon and register. There will be a limited attendance at the event, so register early. And with that, I'm now going to turn it over to Dr. Ronald Kaplan, Executive Vice President of Research at Rosalind Franklin University and Science, the Vice Dean for Research at Chicago Medical School, and a Professor of Molecular Biology. Dr. Kaplan, the floor is yours.
Thank you very much, Ms. Meriwether Argus. We appreciate this opportunity to be with the IOMC today. I'd like to introduce our first speaker. We're going to have a series of short topic talks and then a panel discussion. The first speaker is Dr. Kristen Schneider, our Associate Dean for Research at the College of Health Professions. And the title of her talk is Community Input on Research. Next slide, please. Okay,
thanks,
Kristen.
Dr. Kaplan, and thank you to the IOMC for giving us this platform. I'm going to make the case that community input is essential in research, particularly when we're focused on developing and testing the efficacy of treatments that are designed to improve the community's health and well-being. I'm going to highlight 3 researchers at Rosalind Franklin University who have integrated community members into their research in a variety of ways to ensure that their interventions are efficacious and could be widely implemented. I want to mention that there are a number of ways to engage communities in research, most notably through community-based participatory research, and I'm merely going to be providing a sample of strategies that researchers can use. Next slide. Dr. Noah Rosenblatt at RFUMS, his program of research really focuses on fall prevention, and one population that's at risk for falls are adults with a lower limb amputation. In the over 1 million adults with a lower limb amputation, roughly 50% will experience a fall every year, and about that same amount will report having a fear of falling. While there's certainly overlap in those two groups, in that having a fall can certainly prompt a fear of falling, not everyone with a lower limb amputation who reports a fear of falling has had a fall that prompted that fear. And this fear of falling can create a number of problems in adults with a lower limb amputation, especially those who use a prosthesis, since fear of falling has been associated with avoidance of activities, less engagement in communities, and thus lower well-being and quality of life. And while fear of falling can certainly be driven by poor balance and weakness and lack of strength, in those who use a lower limb prosthesis, fear of falling can occur even when patients have adequate physical ability to safely ambulate. So Dr. Rosenblatt and I were particularly interested in developing an intervention that could really address fear of falling in adults with a lower limb prosthesis. We felt strongly that the intervention should address both physical ability and psychological barriers to ambulation. So we thought that integrating physical therapy to address balance and function and cognitive behavioral therapy strategies to directly address that fear of falling could really be a promising way to increase physical activity and community engagement in those who use a lower limb prosthesis. We had created a combined intervention in which a physical therapist would use virtual reality games as one component of physical therapy, while the behavioral counselor would use exposure, cognitive restructuring, and goal setting with the assistance of the physical therapist. Now, before we tested this novel intervention, we really recognized the value of getting input from patients. And we called on one of our collaborators, Justin Heck, who's pictured here, a prosthetist who also uses a lower limb prosthesis. His expertise as a provider who works with those with prosthesis and his lived experience as a prosthesis user was invaluable in helping us consider what components of this novel intervention might be particularly challenging for patients. For example, since participants may be unfamiliar with or fearful of using a treadmill, even though there would be a harness, he recommended creating videos of the gaming exercises that our participants could watch prior to playing the games to help them feel more comfortable and confident. Here you can see Justin in one of the videos participants could watch prior to playing the game. Justin and several other prosthesis users also ran through the intervention with us in preparation for finalizing the intervention for the randomized clinical trial. His contribution was so instrumental. You could click next. His contribution was so instrumental that we really wanted him to be a part of a symposium presentation that we gave at the Society of Behavioral Medicine's annual meeting, where we discussed the development of the intervention. And I can tell you that the folks that attended that symposium really valued his perspective on the intervention development. And our results our efforts in soliciting community members' feedback and tweaking the intervention accordingly seem to have paid off. Compared to participants in our sham control condition, participants in the combined physical therapy and CBT intervention reported significantly greater declines in fear of falling. And the qualitative feedback that we received from our participants is, one of them is quoted here, seemed also to support the benefits of this combined approach. My next example, I'm going to talk about Dr. Brian Feinstein's work and how community members can provide input on research. Dr. Feinstein's work focuses on sexual and gender minorities, and he has a current study examining whether an online HIV prevention program improves prevention behavior in bisexual youth. While gay and bisexual men are disproportionately affected by HIV, bisexual men in particular are less likely to engage in HIV prevention strategies, and they're also understudied in HIV prevention trials. Since effective prevention really begins in adolescence, Dr. Feinstein and his colleagues aim to develop a sexual health promotion program for bisexual youth using a mixed methods approach that is using both quantitative and qualitative input on the intervention. In designing the intervention, Dr. Feinstein was incredibly thoughtful in seeking community feedback in a variety of ways. He ensured that bisexual men with lived experience were a part of the research team and could inform the mixed method approach at every step. He also connected with a community advisory board of LGBTQ+ adolescents who could provide feedback on survey and focus group questions. He specifically had bisexual youth complete an unadapted sexual health intervention that was developed for gay and lesbian youth to see how well it might meet their needs. And he conducted focus groups with bisexual youth to see what they would want from a sexual health program. Through the qualitative and quantitative data that Dr. Feinstein collected with bisexual youth, he gathered critical information that he used to develop a sexual health promotion program targeted to the needs of bisexual youth. Without this important input from the community, it's likely that Dr. Feinstein's intervention would not be as efficacious or acceptable to bisexual youth. The feedback that Dr. Feinstein received helped him create Be Smart, an online program to improve sexual health knowledge and safer sex while affirming bisexual identities. The program covers a range of topics, some of which are certainly specific to bisexual youth, and it provides interactive activities and tools to encourage HIV prevention. The tailored content for bisexual youth helps ensure that bisexual youth feel heard and validated, which may be instrumental in their engagement in the program and ultimately improve the program's efficacy. Stay tuned for results though, because data analysis is currently underway for this particular program. In my last example, I'd like to highlight how sometimes the community will actually reach out to scientists looking for research expertise. In this example, a substance use program, A Way Out, reached out to Dr. Dave Cosson for assistance with evaluating their program. A Way Out provides a way for law enforcement to facilitate connection to substance use treatment without the threat of criminal charges. Dr. Cosson, and his colleagues collaborated with A Way Out and the Lake County Health Department to provide input to understand how well they're actually connecting folks to treatment and whether there might be unmet community needs that the program could address. These types of partnerships offer a terrific way for researchers to lend their measurement and research design expertise to community organizations that are interested in quantifying program success. In their initial evaluation, they learned that the A Way Out program appears to be doing a good job of connecting folks to treatment, particularly inpatient treatment, and that about 75% of patients had an initially successful outcome. Dr. Cossins continued to partner with A Way Out program to understand how they could reach those from under-resourced communities. For example, A Way Out wasn't initially collecting information on the sexual and gender identity of their participants, so they were really unsure as to how well they were actually reaching sexual and gender minority individuals who are actually at an increased risk for substance use disorders. Dr. Cosson and his colleagues were able to provide guidance with how to best collect this data, and they're now pursuing funding for research that could inform how under-resourced communities like sexual and gender minorities could be better served by the A Way Out program. They're also interested in understanding what other processes that do not require law enforcement could potentially facilitate connection to treatment. So when communities come calling, researchers really should take advantage of these opportunities to improve the population's health. And with that, I'm going to turn it back over to Dr. Kaplan.
I'd like to introduce Dr. Melissa Chen, Clinical Director of our RFU Interprofessional Community Clinic. The topic she's going to discuss is student research quality improvement work within the context of the community clinic. Dr. Chen, the platform is yours.
Thank you, Ron, and thank you to the IOMC for the opportunity to share the work of our campus student-engaged free clinic. The students and faculty have been doing some tremendous work for it. Next slide, please. So the ICC was started by students in 2013 for a two-part mission. First and foremost, to provide accessible quality healthcare for the uninsured of our community, and also to provide an opportunity for students to work with our communities and develop interprofessional communication and teamwork skills with an intentional emphasis on principles of equity. Next slide, please. In the last few years, the ICC has been able to start leveraging the power of research to improve community health and wellness, and has started presenting their work at several national conferences of like-minded students and educators. Next slide. So what does research mean for the ICC? So there are three aspects I'd like to highlight today. One, how it helps us dive deep into learning about the community that we serve and learn about the power of collaboration. Two, how it helps us challenge the systems of a clinic's operations. And three, how it helps us continue delivering transformative clinical care. Next slide, please. So the first topic, the community. Research helps us dive deep into learning about the community that we serve and learn about the power of collaboration. Through research, we learn who exactly are the patients that we are serving and the barriers that they face. ICC students were part of the town halls processing the results of the latest community needs assessment of our section of the county. Maybe in the future, we can get them involved in some of the focus groups used in the next assessments. We also learn the power of collaboration with the community. For example, in making our health education efforts more effective. What kinds of outreach are the most effective in communicating about the ICC? What kinds of health education materials are more successful in our particular communities? A specific example, we've been closely partnering with the North Chicago think tank in the last year, which is a nonprofit created by local citizens to improve the lives of residents. We're discussing things like, what kinds of research questions does our community have? How do we survey a community who is distrustful of medicine's historic misuse of information about them? So a student-engaged free clinic is an incredible opportunity for students to learn about systems thinking and what kind of interventions are possible for addressing barriers to care or equity in a clinic's processes. For example, students have done a lot of work in creating this live spreadsheet. You can see sort of in the bottom of the first poster here. So the spreadsheet breaks down the patient visit and into various aspects and enables us to track data on how long each part of a patient interaction with us takes. And that allows us to make some changes to operations and see the effect with the overall goal of reducing any patient wait time. Or another example, students analyzed why patients were, quote, no showing at their telehealth appointments and broke it down into internal and external factors. They were able to then address the internal factors by changing some of our systemic processes and also started addressing some of the external barriers that our patients face with various proposals. In this particular research project at the bottom here, they analyzed the effect of one of their piloted improvements. And the last example, an analysis of our health behavior change consultations had data limited by the fact that it was up to each individual clinician to refer for a consult. And anytime you rely on such referrals being an individually motivated thing, you introduce variability and even the possibility of bias in making those referrals. So as a result, we are now in the process of negotiating a systems change to standardize the referral process. So these are examples of how we're leveraging the power of research to improve systemic barriers to health at the ICC and help students think at a systemic level at how change can be made. And ultimately, research helps us continue delivering transformative clinical care at our unique interprofessional model. The first publication out of the ICC last year described the uniquely interprofessional model that we have for telehealth. And the second publication, just out a couple weeks ago, described the impact of adding an additional immunizing pharmacy faculty and made improvements to our ability to adhere to vaccination guidelines. Other ongoing research projects include many quality improvement initiatives. I'm so excited about this work, not only to learn about and be able to demonstrate specific aspects of the success of the clinical care that we're delivering, but also excited that the students are learning a deep appreciation of research and QI work through these projects. So these are just a few ways that the ICC is addressing health equity through research and community partnerships. It's a singular educational experience for students. One, learning with and about the communities that we serve and how collaboration creates better care. Two, gaining experience in creating systems change. Students are learning how inequities can be embedded in clinic processes and learning what it might take to make the changes needed. And finally, they're learning about research and QI and the elements needed for transformational clinical care. Thank you very much.
So next topic will be by Dr. Maureen Benjamin, a part-time faculty at RFU and a senior research fellow at Sinai Urban Health Institute. And she'll discuss research collaborations between RFU and SUI.
So before I start, I'm going to tell you a little bit of Sinai Chicago, just to give you the context of the organization that RFU is partnering with. We are part of Sinai Chicago, which is the largest private safety net hospital system in the state. We have the hospitals at the core, they're at the bottom, and then clinics as well. But the parts that make us really unique are the Sinai Community Institute, which offers social services. And then at the top, the Sinai Urban Health Institute, what we refer to as SUI, which is the research wing. It's a community-focused research wing that was established over 20 years ago to address health inequities in Chicago and beyond. On the next slide, you'll see our team picture. I think we are one of the largest, if not the largest, health equity research centers in the country. This picture is pre-COVID, but now we have about 60 people on staff, and we have three main areas of work. So we do epidemiological research, we do community-centered interventions, primarily using the community health worker-led models. We do evaluation and technical assistance, and throughout all of that, we do collaboration with our communities and with partners like Rosalind Franklin. So we've been partners since the very beginning, and we have many different areas that we work together, including teaching, consulting, and partnering on research. But the part that I want to talk about today is the internships. Now in our 10th year of this, we're just getting ready to welcome 15 students for the summer program. Next slide, please. Our summer program, we have a three-pronged educational approach. We do a series of seminars and workshops. I'll give you some examples of those in a minute. We also pair up every student with a SUI researcher to do, for them to help with a research project that we have currently going on. And then we supplement that with a third area, which is book and film discussions. We're adding podcasts this year, and also community tours and volunteering opportunities. So here are some of the examples. I think this summer we have over 30 seminars planned for the interns. We go over the basics like health inequities and determinants of health, but then we also try to get to areas that are probably not covered in traditional medical education, like advocacy. This picture is Roberta Rakoff, who many know is a longtime lobbyist for healthcare reform and for interests of safety net hospitals across the state. We also talk about things like managed care, structural racism, cultural humility, positionality. We have a big range of topics that we bring in experts and have our own team speak about. On the next slide, you can see some of the projects that students are involved with. An example of epidemiology research is on the left, a paper I did with 3 Rosalind Franklin students looking at racial differences in kidney disease mortality at the city level. In the middle, that was a project they did with community health workers, helping to develop a behavioral health module for the community health workers to use in their projects. And then of course, we have a lot of COVID related projects right now, everything from testing, contact tracing, and vaccine hesitancy. The next slide is what I really want to focus on. This is how we involve the community in the development and the practice of this internship program. From the very beginning, 10 years ago, when we were developing this program, we had our community health workers consult on this. They currently give me feedback consistently. I just met with them last month to talk about this coming summer. And they'll tell me things like if they see an area that's missing, that we could do a seminar on. For example, one thing they told me this year is in our session on managed care, I teach that with Sinai's director of managed care. And they suggested that a community health worker sit in on that session and provide input or provide insight on what uninsured patients deal with or underinsured patients. So we incorporated that. We have the community health workers also teach. They teach sessions on the programs that they're leading, as well as we have a panel of community health workers, which is really informal, lots of questions and answers, a great chance for the students to get to know community members and be able to ask questions that they normally wouldn't get to ask anybody. We have sessions on community engagement. How do you do it effectively? And we focus a lot on the communities, getting to know the communities, the history and the strengths of the 2 communities we sit in particular. And then finally, we have community members lead tours. We do, in non-COVID years, we've done 3 big community tours. They're 2 to 4 hours each. And we also partner with local organizations to offer volunteering opportunities, including the Night Ministry and Phoenix House. So I'll end there. Thank you.
Thanks, Maureen. The next topic will be discussed by Dr. Robert Marr, Assistant Dean for Research at Chicago Medical School. Title is Student Involved Research in Lake County. Dr. Marr.
Thanks, Ron. Good afternoon, everyone. So I'm going to be talking about 3 examples of research done in the community in association with Chicago Medical School faculty and students. The first example is from the Lake County Health Department. This was mentored in large part by Dr. Sana Ahmed, who is a medical epidemiologist there, and she's also a faculty instructor with the Chicago Medical School and a recent alumnus of the Chicago Medical School. So this study is shown here, or the title is shown here. Sunit was a participant, a student participant. Basically, as we all know, COVID-19 has caused a lot of stresses on society, and one of those is the stress it put on students participating in education in school and in missing days of school, and this resulted in educational deficits as well as societal or behavioral health issues. So strategies were needed to help mitigate this while at the same time keeping people relatively safe. So that is the topic of the study, is a strategy called Test to Stay, which essentially allows even unvaccinated people to continue going to school, staff or students, teachers, even if they've been exposed to somebody who tested positive for COVID-19, as long as they followed certain, or there were certain criteria that were followed. And those are shown here. So essentially the exposure had to occur while both both persons were masked. The close contact had to remain asymptomatic and continue distancing and wearing the mask, and they had to continuously be tested. And so if this was done, they could continue to attend the school. So next slide, please. So I'm not going to talk about this, so we can move on to the next slide. So basically the summary of the findings, that out of 1,035 students and staff members, only 1.5% ended up with testing positive for COVID. So that's only 16. And importantly, there were no tertiary transmissions at the school. So it was estimated that this resulted in a total of 8,152 in-person learning days that were saved, while maintaining a relative level of safety of about 1.5% transmission. And this study was actually mentioned during a White House press briefing by the CDC, and was used to help make CDC policy, which we are very proud of. And on the next slide, you can see another example from the Lake County Health Department, that this was mentored by Dr. Les Zun, who's a medical director at LCHD. Also, he's the director of clinical faculty development at RFUMS, the Chicago Medical School. And on the next slide, you can see this was a study done, unpublished at this point, but it was a study done as part of one of our students, Sean Hormozian. It's a part of his medical degree with distinction in research certificate that he was doing. And essentially it's a study on type 2 diabetes and on A1C levels, and on the control of A1C levels in type 2 diabetics related to social determinants of health, patient care, and comorbidities. And on the next slide, you can see some of the data tables, which I won't really go over. And so we'll move on to the next slide, and I'll just summarize. So this is a summary of some of their findings. They found that poor control or uncontrolled A1C levels was associated with Latinx, with being male, white, with illicit substance use, and interestingly, with being employed. And on the other end of the spectrum, A1C levels more likely to be controlled for individuals who did yearly lipid panels or metabolic panels, with being Asian and being enrolled in Medicare, which is also very interesting. So on the next slide, basically this is the last example. Last but not least, this is Dr. Ricardo Seno, who's assistant professor in the Department of Physical Medicine and Rehabilitation at the Chicago Medical School. Dr. Seno has been, he's been mentoring students for a very long time. He's mentored a lot of students, and there's a lot of scholarship that has come from this. A lot of what he's done has involved research done on dementia sufferers at assisted living centers. So on the next slide, basically I'm highlighting one of those studies. This was a study looking at polypharmacy, defined as 6 or more medications prescribed to that individual among dementia sufferers within these assisted living centers. And he's looking at the association of polypharmacy with falls, which is a serious problem. And they looked at 3 centers, basically. And on the next slide, basically, you'll see some data that we can skip over to the next slide. So basically, the summary of their findings, that they did find an association of polypharmacy with increased risk of falling. And what was most interesting about the study is there was an even stronger association if the polypharmacy involved excessive prescription of psychotherapeutic agents. Which has implications for prescribing these in elderly demented individuals. And yeah, so hopefully I've given you a nice summary of some research done in the community with Rosalind Franklin University and our students. Thank you.
Thanks, Bob. So the last topic I'll be talking about, and that's our Innovation and Research Park, our incubator Helix51, and our Joanna Briggs Institute, in the context of community impact and engagement. So a couple of years ago, we finished, I need that first slide still. Thank you. We finished phase 1 of our Innovation and Research Park, a brand new 100,000 square foot research building. Some of the goals for this research park in terms of community engagement is job creation and training, economic impact in Lake County, we'll be talking about, regional healthcare infrastructure, and biomedical innovation in the region to improve quality of life. I do want to mention the 2 people who are working with me on this project, Michael Rosen, the Managing Director of IRP as Innovation and Research Park, and Dr. Connie Cleary, Director of Innovation and Industry Relations. Next slide, please. So our Helix51 Incubator, which we opened a couple of years ago, there are currently 8 companies in there. 3 focus on different aspects of cancer research, 2 on cardiac research, 1 on fibrotic disease, 1 on GI surgical infection, and 1 on virus detection. There's a couple of things I want to mention. An incubator is not simply space for companies, but it's most importantly the programming that you surround the companies with. So we bring in experts that basically mentor these companies with respect to intellectual property protection, SBIR and STTR grant writing, FDA regulation, pitch deck presentation, business plan development, etc. Also, with respect to this, the Innovation and Research Park, we formed an external advisory council, which consists of a number of people from the community, industry folks, political folks, venture capital folks, who help advise us with respect to suggestions and how we might most effectively develop the park moving forward. And their suggestions have really been extremely valuable. Next slide, please. Now, this new building that I'm talking about, it's very novel design. It's 4 floors. 2/3 of each floor house our academic faculty researchers. 1/3 of each floor is dedicated to bringing in industry into the building, and industry specifically curated for R&D that complements in some way areas that our faculty researchers are interested in. So far, we've brought in 2 companies filling the 4th floor of this building. The companies are Inspiritech and Shield, Illinois. Inspiritech was an incubator company. They grew and now they occupy about 50–60% of the space on the 4th floor. So the incubator acts and is meant to act as a pipeline into the industry space. A certain percentage of the incubator companies will succeed and grow and need additional space. Shield, Illinois. So Inspiritech focuses on allergen and pathogen detection, extremely sensitive detection. Shield, Illinois focuses on COVID-19 testing. I'll be talking more about them in the next slide, please. So Shield, Illinois is part of University of Illinois. There are 7 sites statewide. Shield, Illinois is responsible for K-12 COVID testing in all of Lake County, Illinois, and in Northern Cook County. So we feel this is a community service that we are doing, giving back to the community. They needed this site set up in about 4 weeks. This was immediately prior to the Delta surge last summer, as it was just getting going. And we were able to accommodate them. And currently they are working 3 shifts, 24/7, in response to the Omicron surge. I mentioned Inspiritech's allergen and pathogen testing. One of our startup companies called Every Place Labs, basically they are developing a kiosk that they hope eventually to place in malls and this and that, where you can have diagnostic tests done on the spot. Right now they are working on COVID testing. So one of the impacts on the community is job creation. Currently in the incubator, there are 8 companies with 16 direct jobs. There's a formula in life sciences, number of indirect jobs that are related to these direct jobs. That's 32 for a total of 48. This is our goal over the next 12 to 24 months. The companies in the industry space, in the larger space aliquots, right now at 132 jobs, this will grow. Now we also have an internship program in our Helix51 incubator, where we basically bring in students from the community, Waukegan College program, Kent School of Law is another, and then also internal students, it's College of Pharmacy, and we just set up the program with Chicago Medical School. And those students either can work with the administrative staff of the incubator, so learn about some of the activities that go on, or with certain companies, depending on what they're interested in, the companies interested are. And then we anticipate this program to approximately double over the next year. Lake County Partners did an impact statement for us as we were developing the concept of this research park. And phase one, which is this first building, they estimated will have an annual economic impact on Lake County of $120 million when filled to capacity. So we think that makes a big difference. We have ambitions for phase two and phase three. So you can multiply this number by whatever multiple you believe we'll be able to achieve, but we have large aspirations over the next several years. And Lake County Partners has been a key partner with us in some of these endeavors. Next slide, please. I'm pleased to announce we have formed a new Center for Health Equity Research. And specifically, this center will focus on identification, elimination, and prevention of health and healthcare disparities in Lake County. We've done this. Maureen Benjamin has been a great consultant and collaborator as we've tried to do this. Following a national search, we have just hired the founding director for this center. We're going to issue a press release about this in the next couple of weeks. I can't quite say her name yet, but we're very excited that this center is up and running. Next slide, please. Okay, I want to briefly talk about our Joanna Briggs Institute Center of Excellence. Jennifer Greenwood is the director of that center. There's an amazing statistic that Dr. Greenwood made me aware of, and that is NIH research shows that the average lag time between publication of a systemic review describing best practice and widespread adoption of that best practice is on average 17 years. Okay, that's a scary thought. Especially if you have a bunch of stuff and you'd like best practice to be utilized as soon as possible. So the goal and the focus of the Joanna Briggs Institute is to provide the tools for practitioners to become careful analysts of the evidence and empowered agents for change so that we can shorten that gap. There are a number of interactions so with our nurse anesthesia residents, there are a number of projects that they engage with at the sites where they're doing the residency. Management of obstetric hemorrhage is one. This is done at a rural site in Illinois with education modules, simulation modules of a number of elements of the staff of that hospital. They are able to reduce the frequency of this terrible syndrome. Similar approach has been taken with management of patients with implantable devices. This is basically an education of the patients adequately, reduces wait times and cancellations of appointments, and increases on-time discharge and increases safety. Yeah, somehow this got, so I said the left-hand side, right-hand side, unintended pregnancy. So apparently this, I learned in this slide, certain anesthesias can interfere with certain contraception. And it's important that the patient be made aware of this so you don't end up with an unintended pregnancy. And also, that's not obstetric, sleep apnea. The appropriate identification and stratification of patients that have sleep apnea and referral to CPAP prior to any surgeries that may or may not be required. And then enhanced recovery from surgeries, appropriate best practice analysis and implementation of paradigms. So these are some of the areas that the Joanna Briggs nurse anesthesia residents are involved in. So one question we wanted to look at was, we've talked about a number of different projects and approaches that have involved community in rather different ways. So one question we were thinking about is, how do you ensure that community voices are incorporated in the planning and implementation of research initiatives? And what lessons have you learned related to community engagement? And so I open that up to the panel, and who wants to start with that one?
I can jump in.
Okay.
I think one thing that's really important is to build consistent relationships that aren't dependent on specific projects or grants. A lot of groups do that because you're required to have a community advisory board, for example, and then the grant and funding ends, you stop interacting with the partner, then a new one begins or a new call for proposals comes out, and you want to get community input, but you don't have a community group to go to. So I think maintaining that is something that is really important. It's hard to do. You have to make sure you're compensating the community members for their time. You have to make sure there's a culture shift within your own organization so that everybody on your side is making sure that they're valuing the other voices, valuing lived experience and wisdom as much as they value things like academic degrees and job titles. So all of that goes into, I think, keeping a consistent presence and trusting relationships so that you can have input when you need it, when the need arises for projects.
Okay. I think one example that I would mention from my experience with the Innovation and Research Park, there was a lot of initial discussion with different organizations within the community about their thoughts regarding our development of this. So for example, with the North Chicago City Council, the North Chicago School Board, the North Chicago Mayor, and you know, there was an educational process going both ways. You know, what their hopes were for this, what their concerns were, how we needed their help. I mean, one of the things, there was an enterprise zone that stopped, didn't quite include our campus. It ended right at Buckley Road. We needed extension of that to include our campus because that would make some of these companies, you know, more competitive and this a more attractive place to land. That required a lot of help from the mayor of North Chicago, the mayor of Waukegan, the city council to get that enterprise zone extended. So very collaborative set of interactions. Melissa.
I'm just going to jump in with a brief example to emphasize what Dr. Benjamin's brought up, the need for the community members to be at the original table making the decisions, right? So the ICC has elected the William Coleman, who's both a community health worker and the leader of the North Chicago think tank, to its faculty board. So he's going to be at the table when all of these decisions and these projects are being made in the first place. And I'd also like to highlight Dr. Schneider's work in creating a community-based participatory research community board for consistent outreach to the community.
Yeah, thanks, Dr. I actually was just going to mention, as a researcher, when I first came to Rosalind Franklin, it was really important for me to get to know the community and start seeing, you know, who, what organizations might be doing work that would be relevant to the type of impact that I wanted to have on the community, and just starting to have conversations with people was really valuable. And especially I'll have to give a shout out to the Lake County Health Department. They've been a wonderful partner in a lot of the work that I've done and that some of my colleagues have done, and really I do really lead the pack in terms of how to do community-based participatory research, and have been great collaborators at connecting me to different individuals.
So question 2 is kind of similar to question 1. So I'm going to move on to the third one. What challenges emerge when working with community partners, and how might these challenges be addressed? I think that's a great question. Anybody want to talk about challenges that they've encountered and strategies they use to try to surmount those challenges?
I can jump in again. One challenge is research takes longer and it costs more. So to do genuine community engagement, it takes a lot of time to set up the meetings. It takes a lot of time to get input. It takes a lot of time to build those relationships. So you have to factor that into the budget or it just doesn't happen. I also think it's sometimes researchers are surprised that community input will take you in a direction that you may not have planned to go. One example of this is from the Sinai Community Health Survey. We had a community advisory board that got to veto every single question on our survey. And that's not something people tend to do, because the first round they vetoed all the questions on religious involvement, for example. And that was one of my lines of work. And there are 0 questions in the first round on that because the community members did not think it was relevant enough or a high enough priority. They also vetoed questions on drug use, certain kinds of drug use. So you have to be okay with the fact that you're sharing power, and that means you don't get to make all the decisions.
Yep. Anybody else on that one?
I have a related question. And have you found that by engaging the community early on, like you're doing, instead of at the end where the reactors to what's already been decided, has saved you time as well?
So I'm going to address that one. So with the Innovation and Research Park, not only did it save us time, but it made it possible. So for example, I mean, I got a tremendous education trying to champion this. You know, the Navy had some concerns about us putting a building that height near their campus. The school board had financial concerns. And the solution to all those concerns was a lot of dialogue at multiple levels in each of our organizations to explain, you know, okay, we see your point of view. What do you think about this? How about if we did this? A ton of conversation before we actually did anything. It was key. Anybody else want to take a crack at that one? Here's a question I see in the chat. How can community engagement groups be compensated? If you can share ideas, this is a big plus. Donation fees. Anybody have experience with that? Compensating community engagement groups?
Yeah, I'll say for a grant that we just put in January, we're definitely compensating our community members who are going to be providing feedback and serving on the community advisory board. And then in the qualitative work that we're going to be doing with community members, we compensate them for that too. When I've had projects where I haven't necessarily had funding tied to them, I've tried other unique ways of trying to compensate in some way. So making sure, for example, there's food provided if we're going to have meetings, just to at least give a meal. And then I also think about the expertise that I can offer organizations as potentially a way of compensating. It might not necessarily lead to a research project that's in my area, but again, like I worked with one organization that really wanted to get some basic information on, like, was their summer program for STEM helpful or interesting at all to the youth in the community. And so we just put together like some basic evaluation for the kids and their parents to help them, to help guide that evaluation, and then also analyze the data and gave them a report. And so, you know, that was something that I just did to sort of foster and strengthen my relationship with that group.
Yeah, and I know for, I think it was one of Dave Costin's community projects, he had asked for pilot funding to help compensate some of the participants. Yeah.
I just was going to build on something Kristen said, that of course we pay our community members for any time on a committee or taking a survey, anything like that, but offering assistance, amplifying their voice. So if they have an event, we put it out through our channels. We host things like the Sinai Population Health Institute, and we invite our community advisory members to attend that institute free of charge. So any way we can kind of even out the benefits, we try to give back to them.
Got it. I think another important topic that we should discuss, in what ways has student involvement in these projects facilitated their development as healthcare providers and researchers And what are the most impactful student outcomes from student engaged community projects? So, I mean, those are related and I think important questions.
I think Dr. Chen really did a good job on one of her last slides, well, on the last slide that she presented, talking about all that. And there's so many advantages for students. I mean, they get insight into their communities through doing this research. They gain, you know, practical experience with research, and they're going to be lifelong consumers of research. And hopefully, you know, I think as the Assistant Dean for Research, I hope that this inspires many students to become lifelong researchers once they graduated and take on their professional roles.
Let's build on that for a second. I think one of the goals, overall goals, is just to shift their perspectives that, you know, the answers are not all found and up to date or in the New England Journal of Medicine. You know, many of the answers are found in the community. So my hope is that, you know, by working with the community, that their lens gets shifted.
There's a question in the chat. I'm sorry, did I interrupt? I'm sorry, go ahead, Kristen.
I was just going to say, I'll give a real quick example of how this can be beneficial to the students. I had a student for her dissertation. She applied for some funding to get funding for her dissertation. And as part of the project, we're having her put together a community advisory board. And that was one of the specific things that she did. She was ended up successful in getting the money. And it was one of the things that the reviewers commented on, is how that was such a strength of the project. So I think there's certainly benefits to the individual in having those folks a part of it. It also, I think, really benefits the science too.
Got it. There's a question in the chat. This is a good one. How can achieving health equity be measured? What is working, what's not? Maureen, you want to take a shot at that one? Or?
I hope I can try to answer it. This is what I've been trying to do for 17 years now. You know, we measure it at the population level. So not just at the city level, but as granular as you can get. So at the neighborhood level, comparing various outcomes, you know, from mortality rates to health diagnoses of chronic conditions. And then we do it at the program level, right? So you can see if a program is working or not. It's really difficult because some of the numbers we're trying to sway, like the black-white difference in life expectancy in Chicago. How do you move life expectancy, right? That's a very ambitious goal. That's something groups like Westside United are trying to attack, and they're measuring it in a lot of different ways. But I think you have to think broad. You have to think of each step. So looking at life expectancy gap, what's the main cause that's contributing to that gap? Okay, so say it's heart disease, what's leading to differences in heart disease? And then going down to the community level and saying, is this project working? If so, let's build it up. Let's increase policies. Let's change, you know, at the highest level we can.
So I think to kind of summarize, you know, take home messages, I think from, you know, looking at all the talks, community input is essential to facilitate the most impactful research. That there's kind of a continuum of the level of community input and research, you know, going from outreach and consultation all the way to full collaboration and shared leadership. That advancing down that path sometimes can be difficult and time consuming and costly, but ultimately results in more accurate and more impactful research. So I think our shared experiences support that, that view. And then the other take-home message I would say is including students in research with community members really facilitates their interest in partnering with communities, learning at a real hands-on level what it's like to conduct this type of research. And when they become healthcare professionals, hopefully increases their interest to address more comprehensively population health issues. Does anybody else have thoughts about other take-home messages that they think are not included in that. And everybody here helped me with those. So I'm an academic. I want to make sure I give credit where credit is due. But are there any other gems that, perhaps we should emphasize?
I think one of them is, I think RFU is very unique in this area because of the comprehensiveness of the approach, the long-running commitment to addressing health equity and disparities, and to engaging the students and the community. Again, I've been at many different locations working with providers and organizations, and this is truly remarkable. The integrated comprehensive program that you've put together and continue to grow. And I look at the innovation centers and just think, oh my gosh, not only are they doing the research and putting together products and services, they're also employing people in the community. Again, it's really a tremendous program that you've put together. So many programs coming under the umbrella of health equity and advancing care. So I thank you all for your contributions, not only for today, but all that you are doing to make a difference, truly a difference in the lives of patients and also in those that serve the patients as well. I just want to remind everyone of the IOMC Healthcare Awards. The closing deadline is May 4th for all submittals. Please see the IOMC website for more information. I thank you for attending today's session. We also hope to see you at the fourth and final virtual session on April 29th on building networks to solve critical nursing workforce needs in the greater Chicago area and metropolitan region. I know this is a hot topic, and I know that everyone's interested in how we can work to solve the critical nursing workforce needs. Look for the survey link to obtain your CEUs for today's session, and please follow us on LinkedIn. Check out our blog and visit the IOMC website for more details. And I just want to say again, thank you all for what you're doing, what you shared with us today, and what you continue to do to make a difference. Thank you.